Thank you very much for the invitation to speak today. So my task today is to show you how we could take discovery research, liquid biopsy research into the clinical arena in the context of clinical trials. So I think I'm a hematologist who treats patients with lymphoma, and I think lymphoma is a very good model to study liquid biopsies in the context of clinical trials. Lymphoma is a cancer of the immune system. It typically starts in nodes, what you see in green is normal lymphatic system. So it presents with lymphadenopathy, but it could spread to other organs. The most common lymphoma is an aggressive lymphoma called diffuse large B-cell lymphoma. It grows very fast in sheets, and so what you see under the microscope is these large sheets of big cells that are rapidly proliferating. And when we first make the diagnosis, we see where the lymphoma is. Because it's so rapidly proliferating, it's taking up a lot of sugar. And what you see is a PET scan on the right-hand side. So limited stage disease would present like with large nodes, for instance, in the chest, whereas advanced stage disease is presented here with all the arrows pointing to lymphoma sites. So even in the widespread setting, lymphoma is curable with chemotherapy. The traditional first-line chemotherapy consists of 5 drugs, 4 chemotherapy agents, and 1 immune therapy called rituximab. It's an antibody that targets CD20 on the surface of lymphoma cell. It is the therapy that has really revolutionized lymphoma therapy for years and years, and to this day, R-CHOP remains pretty much the standard of care. It cures about 50% of patients. And the rituximab, the way it works, once it binds on the lymphoma cell, it's telling the immune system to attack it. So it's cell-mediated, complement-mediated cytotoxicity. If this doesn't work, the new standard of care in second line is cell therapy, which is a different type of immune therapy. And in the second line setting, CAR T cells can cure 55% of patients, and in the third line, 40% of patients. But CAR T cell therapy has challenges. It is a custom immune therapy whereby the patient undergoes pheresis to collect the patient's immune cells. The cells are then, they travel to the States at the main lab where the cells are infected with a virus that produces the CAR, which is at the surface of the cell. And then it's grown in culture, flown back to Canada, where we infuse our patients. And then the cells grow in the patient and they kill the lymphoma cells through cell-mediated cytotoxicity. Now, this is a time-consuming process. The entire time takes about 10 days, and the delays can impact income, but it's also toxic. The 2 most common side effects are cytokine release syndrome, which is like a vascular leak syndrome where the patients can have hypotension, hypoxia. They can go to the ICU in about 20% of cases, and they can get this ICANS. It's a neurotoxicity where patients get confused. They can even get cerebral edema and have seizures. But also, there's a financial toxicity involved because each product for 1 patient costs $500,000. So the efficacy and the toxicity of CAR is very dependent on the tumor burden. And I apologize for the quality of these images because this is what I took with my iPhone. This is a real patient of mine. The PET scan when she was in complete remission in May 2024, and then a few months later, when her disease recurred and the lymphoma involved her entire chest wall and is now spread to the other side of her chest. So unfortunately, this woman, despite further therapy, we weren't able to provide a cure for her. She's now in palliative care. The idea is, can we treat patients at an earlier time point when the therapy is more likely to be effective and less toxic? But the question is how to identify those patients. So you've heard liquid biopsies is a way to monitor patients' cancer non-invasively. It's used in many different cancer types. Lymphoma is not an exception. So when we make the diagnosis, we use tissue, but the DNA from the lymphoma can easily be detected in the peripheral blood. There are two different assays, 2, 3 on the market, but the most widely used are the Avinio and Foresight. It provides the advantages, provides non-invasive monitoring of your lymphoma. It's sensitive to 1 in 10,000 molecules. Foresight is 1 in a million. It predicts outcome if you look at the amount of ctDNA in diagnosis, cycle 2 of chemotherapy and end of treatment, but it's very expensive. They're charging $7,000 per test. So for a patient that requires 3 samples, it costs $21,000. So the idea is to develop our own homegrown assays that we could use in Canada on a much more realistic scale and being more cost effective. So my research has looking at lymphoma genetics, and we looked at a lot of lymphoma biopsies at the time of relapse and developed a panel that could detect the mutations that are most common at relapse. It's kind of a Wayne Gretzky approach of looking at the tumor, so to skate where it's going, the puck's going, as opposed to where it's been, right? So we have made a list of 170 genes of the most common mutations, and we see certainly recurrent mutations that impact the ability of lymphoma cells to die under chemotherapy with R-CHOP. So it confers innate resistance to chemotherapy, and some mutations that are acquired with R-CHOP. So for instance, mutations in CD20 or MS4A1 is the gene. So that avoids the lymphoma cell is not being targeted, no longer targeted by CD20 antibodies. So we have a clinical trial currently at the Jewish called ZUMA-23, whereby we have patients with newly diagnosed lymphoma that are treated with R-CHOP, and they're randomized to either get R-CHOP or a CAR T in the frontline setting. So the idea is for the past 20 years, we've tried to improve on R-CHOP. Nothing's worked. Maybe if we use CAR T in the front line, that's going to be the winner. So we understand that we can cure 50% of patients with R-CHOP. By giving the CAR T, which I suspect this arm will win, we will be over-treating 50% of patients. So can we give CAR T only to those who we know will have relapse disease, and when the disease state is minimal? So to test this, we are doing this in a clinical trial where we're testing testing our ability to use ctDNA profiling in real time so that we can get results in a short amount of time that we would be able to change clinical management in the context of a trial. So we've currently enrolled quite a few patients. This trial has started in end of February of this year. And how we do this is we collect the DNA from our patients. We extract the DNA in our lab. We prepare the library, and each DNA molecule has its own molecular identifier so that we can follow the different mutations. And then we perform hybridization and capture. So the capture is our probes are designed to bind to the DNA sites of interest. And then we use kind of a magnet to extract only those genes of interest. And then we sequence them to 150x. And we do this at multiple time points. And then one of the challenging aspects of this is to understand what's real and what's not. We always compare our tumor to normal to exclude polymorphisms. We align the reads, and we have to filter with high quality reads, low quality reads. We've done this on 600 samples taken from 250 patients that were retrospective, so we already know their outcome. And this is just using a leftover plasma from EDTA collected samples, and we're doing it prospectively with Streck tubes that preserves the ctDNA. So on our retrospective samples, we show that that at diagnosis, the amount of ctDNA in your blood correlates with prognostic factors. So the higher the number of the IPI index, the worse the outcome, the higher the amount of DNA in your blood. Clearing your ctDNA after 2 cycles of chemotherapy is associated with a better outcome. So that's a potential time point that we could use in the future. And having ctDNA at the end of treatment also predicts for a poor outcome. All patients have experienced relapse. Could we use this in the follow-up setting? So patients who are in remission, who no longer require PET scans, because that's not the standard of care, can we use ctDNA to predict relapse 6 to 8 months before relapse occurs? And what you're seeing here are the dynamics on the y-axis are the variant allele fractions of each of the mutations in the peripheral blood of that patient, which then falls after 2 cycles and then rises once there's a relapse. In the right-hand figure, you see that, months before the clinical relapse, we can certainly see a rise in the ctDNA. So, and most of the patients had detectable ctDNA 2 to 6 months before. There are mutations that are associated with early relapse. Not surprisingly, those are genes that inhibit apoptosis in lymphoma, and there are some that are associated with clinical response. So the genes themselves can be prognostic. In our prospective study, we're collecting the samples before cycle 1, so a diagnosis, immediately after 1 cycle, and after 2nd cycle at the end of treatment and in follow-up. And the primary endpoint is how fast can we get a result of ctDNA profiling in real time. The goal is to have it within 3 weeks because that's the cycle length of our CHOP. So this is just an example of our first patient. He's a 45-year-old man with very aggressive DLBCL. All of the lines that you see are different mutations in his blood. And after cycle 1, he failed to clear his ctDNA, and there was a rapid progression. On the right, we get a readout of all the different genes that are mutated in his blood at the different time points, so it's easy to track each one. This is an example of one who did well. And it's an example of a patient that, you know, is, in my mind, in clinical remission, because she had a PET scan that was negative after the end of treatment. But the mutations that we're seeing are in genes that are heavily in places that are very repetitive in the DNA sequences. So there's different quality calls. So we're keeping track of it, but we suspect that what you're seeing here is actually not real. But we're following this to see where this is going. And this is an example of a patient where, you know, there's a fall in ctDNA after the first cycle, but clearly, you know, there's progression after the second cycle, and there was, at the end of treatment, there was a positive PET scan. Our average turnaround time is 15 days, and those who have progressive disease is clearly visible after one cycle of our CHOP. And this is a kind of a summary of all of our patients so far. And you could see in red, those that have progressive disease have, you know, you could tell right after one cycle that this is not going to go well. So in summary, ctDNA profiling in real time in the context of clinical trials is feasible, predicts primary treatment failure after one cycle of our CHOP. Bioinformatics support is critical, and we believe that it's ready to use in trials that will change clinical management. And these are my acknowledgements. The wet lab work was done by mostly my grad students, which I'm grateful for. Bioinformatics supports in Vancouver, and all of the primary investigators at the sites that are providing the patients for this trial. Thank you for your attention.